Listo, ya pueden empezar.
Listo, doctora. Okay, hello everybody. Welcome everyone to our monthly webinar session in CODET Vision Institute. We're transmitting from Tijuana, Mexico. My name is Dr. Adriana Valdez. I'm the Chief of the Pediatric Ophthalmology and Strabismus Department. And this time we will be in charge of the session, of the monthly session. We're going to start with a very special guest. We have Dr. Ali. We're very honored you accepted our invitation. He's from the Hospital for Sick Children in Toronto, and he will be talking about an update on management of cataract and ectopia lentis in children. And then we are going to present two very interesting cases related to the lecture of Dr. Ali. And then we will have a round table discussion and then some questions and answers from the audience. So let's start. First, I'm going to introduce Dr. Ali. He has an undergraduate in electrical engineering at the University of Waterloo, ophthalmology at the University of Toronto. Then he made two separate fellowships, one in pediatric ophthalmology and strabismus in Washington University, and then another one in cornea and external disease at the same place. And currently he is ophthalmologist in chief at the Hospital for Sick Children and the University of Toronto. So welcome, Dr. Ali. And I'll let you then.
Thank you very much for that kind introduction, and thank you to Dr. Valdez for inviting me to speak. I'm just going to share my screen. So I'll be speaking today about management of cataract and ectopia lentis in children. I'm going to be talking about cataract first. And really, I'm just going to go over some of the newer questions and controversies. I'm not really going to be able to talk about everything in the amount of time we have, but if there are any questions, there is some time for discussion at the end, and I hope I'll be able to answer some of those. So with regards to cataracts, these are some of the things I'll be discussing, including workup, timing of surgery, which is a very current topic, all aspects of optical rehabilitation, including contacts and IOLs. I'll talk a bit about bilateral surgery and persistent fetal vasculature outcomes. So let's first talk about workup. I mean, these are questions that I often discuss with my fellows. And I want to talk about what I do practically. Unilateral cataracts are not typically associated with any systemic or metabolic diseases, and by and large, lab tests are not warranted in these patients unless you see something systemic, which is of concern, or on the history itself. Many cataracts are often PFV, and as a tip for the trainees, this is one of the first things for you to look at. Bilateral cataracts are much more likely to be associated with systemic and metabolic diseases, although by and large, they're still largely genetic in nature. We'll test for disorders of galactose metabolism, which are routinely tested in some countries at birth, but if you're specifically concerned, that can be tested for specifically. Torch infections, and for metabolic diseases if you suspect something systemic is going on. In our setting, we will do a karyotype if the child is apparently dysmorphic. And now there's a good gene panel, if the family wants it, especially there's one from the UK. And in that case, about 50% of the time, you will have a positive result, especially in a child with bilateral cataracts or with a family history, although this doesn't really affect management very often. The more significant question to me is when to operate. So let's first talk about what is a visually significant cataract. So the IATS definition, and I'll talk a little bit more about that study, defines a visually significant cataract as being one which is central and at least 3 millimeters in size. The timing, by and large, for most people is before 6 weeks of age for unilateral cataract and up to 10 weeks of age for bilateral cataract. And over time, these numbers have actually gone up. My predecessor at the hospital, who did a lot of cataracts before me, would routinely operate on children at 2-3 weeks of age. And what we found was is that the risk of glaucoma goes up significantly the younger the child is. You do decrease the amblyopia risk and get potentially better vision, but the rates of aphakic glaucoma are quite high. On the other side, if you do wait too long, late surgery will lead to nystagmus, and you can start to see nystagmus developing at about 2 to 3 months of age in most children. And although it's sometimes reversible, often it is not. So what are your options for optical rehabilitation after cataract surgery in infants? The three major options are glasses, contacts, and IOLs, and I'll be focusing mostly on contact lenses and IOL implantation. But glasses are a very good option, especially in children with bilateral aphakia. It can be used actually in monocular cataracts as well. And it's definitely better than nothing at all. There's some other advantages. It's easy to change the refractive power, but the disadvantages are that they can be expensive, very heavy, and they cause optical distortion. For younger children, they manage the distortion quite well, but in older children, they can be bothered by the changes in field and the distortions, the ring scotoma that forms. So one of the biggest question then is rehabilitation with a contact lens or an IOL. And on the side of the contact lens, it's very easy to change the refractive power. And when we talk about the IATS study, there's less chances of membranes and other reasons for reops. And overall, you can have less surgery with a contact lens alone. You always have the option of implanting a secondary lens later after your lensectomy and vitrectomy. The advantage of having a primary intraocular lens is that you can have constant vision stimulation. There's some question of whether it's cost effective or not. And the data is all from the United States, and it may not be generalizable to any other country. There's also a poor ability to predict the IOL power, and there's a questionable effect that's protective against glaucoma, although I'm not sure that the evidence has actually proven this to be true. So the suitability of IOLs is really one of age, and we'll talk a little bit about diagnoses, but by and large, for most of us, it's really a question of how old is the youngest child you'd implant an IOL in. And really, over about the age of 1, most surgeons will do it as standard of care or 2, and that really is generally settled within the field of pediatric ophthalmology. There is some controversy over the use of IOLs in younger children, and the theoretical advantage is that a constant refractive correction is better than contact lens use. And I'll talk a little bit now about the IATS, the Infant Aphakia Treatment Study. And this was a landmark study in this area that was done through the National Eye Institute in the United States, a prospective randomized multi-center study. And this is a study of unilateral cataract. And that's really important because the findings are not necessarily generalizable to bilateral surgery. And they randomized 114 infants to either primary IOL and glasses or aphakic contact lenses. And the primary outcome was vision. The inclusion criteria was the visually significant cataract that I talked about with the central 3 millimeters, and surgery was done between 1 and 6 months of age. The main outcomes were the 1 and 5-year visual acuity results, and there are now some papers coming out on 10-year results when they took the same cohort of patients and have brought them back, although the findings are generally the same as at the 5-year results. And the most significant take-home message from the study was that there was no statistically significant difference between the groups in terms of vision, and there was a trend to better vision in the contact lens group, but this was not significant. The median age of surgery was about 2 months, and the main finding that was different between the IOL and the contact lens group was the rate of both intraoperative complications and post-op complications. The intraoperative complications were higher in the IOL group. These were mostly related to iris prolapse or hyphemas because of implanting IOLs in these very small eyes. But it was in the adverse events where in the post-op period that there was really a large difference between the two groups. These adverse events were mostly cortical proliferation in membranes. In the contact lens group, it was 56%, in the IOL group, 81%. And they had other complications which were single and with the exception of the contact lens related, also were not really related to the type of surgery performed. The reoperation rates that you can see are much higher in the IOL group, 72%, and these were membranectomies and vitrectomies to clear the visual access and not secondary IOL implantation. So just to summarize, at 5 years, there were equal visual outcomes, but a much higher rate of reoperation in the IOL group versus the contact lens group, 72% versus 16%. The other thing that they also looked at, there's also papers that you can read on glaucoma, on the PFE subgroup, on contact lens outcomes and strabismus, for example. The one that I wanted to highlight was that there was a higher rate of glaucoma and complications in PHPV, in persistent fetal vasculature. And just to be very clear, in this study, the PHPV was mostly anterior and not complicated with a lot of posterior involvement. There, like any study, the number of criticisms can be raised. One of them was the post-op steroid regimen in which they mandated a minimum number of drops of 4 times a day, and authors have brought up that in practicality, most people use more than 4 times a day. There are also some question about the experience of surgeons and the volume they contributed to the study, and there's an editorial about this, but by and large, most people accept that this difference does exist. There's also more recently a number of other studies from the same group of investigators, but this was a retrospective study of children who were not in the IATS group. And there's a number of papers on the unilateral cataracts as well as bilateral cataracts, and those are the most recent ones that have just come out. Some are just in press. And these are for older children. So if you remember, the IATS was from 1 to 6 months. The TAP study is on children who are 7 to 24 months in age. Again, without going through all of the criteria, the exclusion criteria were similar to those in the IATS study. So there were, we talked about PFV. So any PFV that was causing stretching of the ciliary process or retractional detachment, any signs of uveitis, retinal optic nerve disease, traumatic cataracts, pre-existing glaucoma, corneal diameter less than 9 millimeters. And these were similar to those in the IATS. Again, the most important findings were in this table here, and this is in the one of the unilateral papers, TAPS. And this compares the results of the infant aphakia treatment study and the toddler aphakia and pseudophakia treatment study, the TAP study. And I want you to look here, and you can see the adverse events were much higher in the infant aphakia treatment study. So the rate of visual axis opacity, the rates of glaucoma and correctopia were much higher in the IATS study. And the real differences between these groups are that in the toddler study, they're older. They're basically 7 months to 2 years in age. The re-op rate, again, was 72%. If you remember, in the IOL group, in the TAP study, children getting IOLs, the re-op rate was only 16%. There are a few other important points. The TAP study was a retrospective study. Even though it was the same group of surgeons, this is a retrospective study. Some details of the surgery were slightly different, but then by and large, this is very interesting, and this is in keeping with some of the other findings from some other studies in the literature. This particular paper is in the journal, the Blue Journal, Ophthalmology, and this talks about this and other studies, and concludes in a very similar way that age is a significant difference in terms of the outcomes of IOL implantation in children. So for unilateral cases under the age of 7, there's no difference in visual outcomes, but increased number of surgeries. But one of the important things to keep in mind, and this may vary depending on where you practice, in this study, all the children who had contact lenses were given them for free. The parents are very motivated, and the cost was quite affordable, and the contact lenses were easy to get. And that's not necessarily something which is true everywhere around the world. It assumes, of course, excellent follow-up as well. And these are some of the reasons why, when I talk to surgeons from different parts of the world, they may gravitate towards implanting IOLs at an early age. From age 7 months onwards, the results are much better. There are much fewer complications. And one of the important take-home points is that all children under the age of 2 who have cataract surgery should really be cared for by experienced surgeons. There is a significant learning curve in younger children, especially with IOL implantation. And this is really a specialist area. The case for bilateral implantations can be made. The outcomes, again, from the TAPS papers for the bilateral cases is generally very good. And the visual outcomes are excellent, which is also true for bilateral cataracts in general. And I don't think, personally, I don't believe it's a significant factor either way. So I want to talk a little bit about IOL calculations. Ideally in children, if you can do it, a clinic-based measurement, especially with something that's interferometry-based, such an IOL master is best. But under general anesthesia with A-scans, I prefer immersion and having an autorefractor for keratometry. Your Holiday 1 or SRKT are both excellent. There are a number of different studies in pediatric cataracts that talk about different IOL formulas, and by and large, no formula is significantly superior over the others. And that includes, say, for example, the Harford-Q for a shorter eye. The target refraction goals, really, what is your goal? Is it emmetropia as an adult, which is most of the time? And this is good for bilateral cases, or if you need emmetropia right now in children who are non-compliant with glasses and non-compliant with patching. If you're doing monocular implantation, you really need to ask yourself some questions. What is the refractive error in the other eye? Will the children wear glasses? And how do you minimize anisoconia? And children can tolerate up to 6 diopters. Sometimes you may consider putting them into contact lenses as well. In binocular cases, anisoconia is not an issue. You may choose to do monovision, although I generally don't do this. And of course, questions such as, will they wear glasses in children who are developmentally delayed? And is there a family history, especially that of myopia, in which case you would be more inclined to aim for hyperopia? The target for adult emmetropia, there are many papers on this. There's really no one formula that is the best. You can either use a percentage reduction in IOL power, depending on age, or a target refraction. In the infant aphakia treatment study, they used a target of +8 for children under 6 weeks of age and +6 from 2 to 6 months of age. There's another formula here, which is up to age 4, where age plus target power equals 4. Sometimes people will do this up to 6. Most of these studies have a wide amount of variability, of course, depending on axial length elongation, depending on amblyopia treatment, and other factors we don't really understand. So look at the family history, counsel the family, and there's a higher rate of refractive surprises than adults, and the prediction errors in size. And the formulas are not really optimized for the set of values that you will get in young children. Just to talk a little bit about technique and to break things up a little bit, this is, I will do a lensectomy and vitrectomy with a cutter and an anterior chamber maintainer. There's many ways to do this, of course. The advantage of using a cutter is that you can do most of the surgery with a single instrument, and if you're lucky, do it with only one entry into the eye. I usually use a 23 gauge vitrector. People have used 25 gauge successfully as well. Vision blue is not normally necessary. This is just for context, is a 2-month-old child having this cataract removed. And I will use a vitrectorexis in very young children, and because you can make them very strong and secure, and you don't really need to do a needle or forceps capsulorhexis. And in these patients, it's important to make the anterior and posterior capsulotomy the same size. You can also switch your hands. I strongly believe that when you do this surgery, you shouldn't allow the chamber to go flat. It increases the rate of synechiae and inflammation. So I will put some viscoelastic in if I'm switching ports or if the chamber is going to go flat. And here we're just enlarging the posterior capsule to make the two the same size. And we close with the tenovicryl, so we don't need to take them back to the OR. The other thing that we do is we also put the contact lens. So this child has no IOL. We will put the contact lens in at the end of the case. And I'll skip ahead here for the sake of time in terms of this is an older child here, and we're going to do a capsulorhexis. In this case, this child is about 5 years old. We will do a primary posterior capsulotomy and anterior vitrectomy, usually at our hospital up until about 10 years of age. I like to do hydrodissection, not everybody does. I just find it speeds up the removal of the cortex. And you can see here, you can prolapse the nucleus out in some of these cases very easily. Use an irrigation aspiration. Some people will use irrigation aspiration, but when you can get the same results. With this, you can do your anterior vitrectomy as well. So this technique, I will be implanting the IOL and just a foldable one-piece hydrophobic acrylic lens, and then actually use a pars plicata, pars plana approach to remove the posterior capsule and anterior vitrectomy. You can also approach it from the front as well, and they're again different. I'll actually do both in my practice. Depends a little bit on my who's with me and the fellow, and how comfortable they feel. And this is a very controlled way of doing it, and this is actually the way the surgery was done in the IETS. But I know some people will go from the front, and you can get very good results that way as well. But there's more distortion if you have to push the IOL aside. I don't like doing the posterior capsulotomy before the IOL implantation because I often see that can cause problems. And you can see here, your posterior capsule can be made slightly smaller than your anterior capsule, and you just close here, wounds here, or you can use a trocar as well, of course. Okay. So the complications of cataract surgery are fibrin and membranes and the refractive surprises. Usually again, with experience, the rate of fibrin and membranes goes down. The long-term complications of glaucoma, which is both aphakic and pseudophakic, retinal detachments are significant, and the family should be counseled about the need for a lifetime follow-up. You aim for -3 refraction after, and we use bifocals at the age of 3. Rapid changes in refraction can indicate glaucoma. It can maybe one of the earlier signs before the IOP goes up. And typically we patch unilateral cataracts 1 hour per month of life. There are a few points here. One is about bilateral surgery at the same setting, so under one general anesthetic. The risk is that of anesthesia versus bilateral endophthalmitis. If a child has, especially an infant, has cardiac abnormalities or other health issues, it may be better to do 2 surgeries at one time. And what we do is we use different equipment sets, re-drape, re-prep, re-scrub, and use different lot numbers. We've done, we had published on 106 eyes in JPOS, and there's really no difference in terms of the surgery or anesthetic problems between either immediate or delayed bilateral surgery. And this is obviously more time efficient in the OR and also for the parents. One last point on the cataracts was about PFV. And I've talked about this earlier. It's a significant cause of unilateral cataracts with ipsilateral microphthalmia. Very variable in presentation. As you can see here, you can sometimes see a fine stalk, sometimes nothing at all. And sometimes there's a lot of posterior involvement, as you can see on the top right. There's been no previous surgery. You just see a retinal fold and this abnormal retina around it. The risk of glaucoma is higher and the risk of detachment is higher. We had also published in this area with a group from our hospital in 58 patients over 28 years. And the risk of a glaucoma in that group is 36%, but a significant detachment risk of 19%. The other part, which is interesting, is that there was a poor outcome with a pars plana or pars plicata approach versus a limbal approach. And some of the group on this were retinal surgeons. Well, the reason we think that this occurs is because a lot of patients with PFV have abnormal retinal bands that attach to, for example, the ciliary processes and are very anterior. And so you may cut these when you actually go in through the pars plana versus a limbal approach because you're not able to see them. So I'll spend a few minutes talking a bit about ectopia lentis. Ectopia lentis is lens movement, which is anterior, posterior, horizontal. The direction of the horizontal dislocation is not diagnostic. And you look for irido or phacodenesis as early signs, especially in young children. The zonules will elongate and break, but except in homocystinuria, in which they will break earlier. And you can see here on this image that the lens adopts this polyhedral shape. And that's because the lens is very elastic. In adults, it tends to stay round. The other signs are progressive myopic astigmatism, and you can get this irregular astigmatism and abnormal higher order aberrations as the lens becomes more deformed in shape. One of the questions which requires some judgment and experience is when to treat these patients. And here's some pointers. So when you assess the lens status, you want to see where the edge of the lens is. And as the edge of the lens, it gets into the visual axis, it causes more and more distortion. And you can see this on retinoscopy. If the lens completely subluxes out of the visual axis, no treatment is required. And you can treat this patient as an aphakic and not subject them to surgery. They do not get inflammation. If their decision, if you also should assess their vision. And after you've corrected for spectacles, if you're not getting improvement in vision with that and amblyopia therapy, you can also consider surgery. The surgical approaches, just to simplify, that you can either do a lensectomy vitrectomy or you can do a lensectomy alone. If you remove the bag, you can consider not using an IOL at all, which is a conservative approach and has a long track record and works very well with either glasses or contact lenses. Your IOL options as other primary or secondary options include scleral fixation with sutures or haptics within the sclera, or iris fixation with either sutures, iris clip lenses, or ACIOLs. If you preserve the bag, some authors prefer to do this. You can do sutured capsular tension rings, Sioni rings, or segments. So in children, especially iris sutured IOLs or scleral sutured IOLs with Prolene, there are high dislocation rates that are reported. ACIOLs are also not a good idea in children, and they can be associated with significant complications. Your other options include aphakia, iris clip IOLs, and these have long-term data. You can also do bag preserving techniques using, for example, Gore-Tex sutures, and these have also had good results. There's not very many good comparative head-to-head studies, and often I find that it's surgeon preference that dictates what is done. Now, the differential diagnosis is mostly Marfan and most significantly fibrillin-1 mutation-related ectopia lentis. So these children don't have all the criteria for Marfan's, but have a fibrillin mutation. Homocystinuria, trauma, ectopia lentis, or pupil, and ataridia are the most other common causes. And everything that's there on the right are actually quite rare and are rarely seen. Marfan syndrome is associated with fibrillin-1 mutations. The zonules elongate. The lens can dislocate anteriorly, but this is not unusual. This is unusual. You need to send these children to a cardiologist or pediatrician to look at the modified Ghent criteria, which I'll show in a sec. And as I mentioned, these children often will have these mutations, but do not have Marfan syndrome itself. They're at increased risk for retinal detachment, and even without any therapy whatsoever. These are the Ghent criteria in which ectopia lentis is actually a major factor, as well as aortic root diameter. Family history is a significant factor. And then many of the systemic features are scored, for example, the wrist and thumbs, the pectus carinatum, various other sort of joint and limb proportion criteria that are there. But don't forget that ectopia lentis is very significant, as well as myopia over 3 diopters. There are different ways of doing this. This is a child who's having a lensectomy and vitrectomy. You can see the shape of the lens. I will keep the bag just to make sure I can remove all of the cortex. And these are just iris hooks. You can also use capsular hooks as well. And it helps with the capsulotomy. And 2 hooks here. It stabilizes the bag. The reason I do this is that I'm not a vitreoretinal surgeon, and this way I can keep all the material within the bag and remove it. It's very easy to remove once you stabilize the bag. You can make sure all the cortical material is removed and doesn't fly around the eye. Once you've removed all the cortex, you can then remove the hooks and remove the bag, do an anterior vitrectomy, and actually the case is done through 2 small incisions, not counting those for the iris hooks themselves. Obviously, if you're going to keep the bag, you can then implant things and suture the rings, for example, in segments, and then suture the bag to the sclera. And then the bag can be removed here. If you leave a little bit of bag, it doesn't cause any inflammation, and it won't cause any problems with the visual axis. Okay. And this is a case with ectopia lentis. And I'm just going to speed through this just to show you an artisan lens implantation. This is done, in this particular case, I'm doing it in front of the pupil as a primary lens implant. I do it through scleral tunnels. You can also do it through a corneal incision, although it can be harder in these eyes. They're very soft and flexible in a young child. And these are often used this is the aphakia version of the lens. And it's a PMMA lens, it's not foldable. And once you've implanted into the tunnel there, you've decreased the size of the wound. It's a 5.5 millimeter wound. You can then rotate the IOL into the horizontal plane. And the attachment of the lens is by inclination. You hold onto the lens with the special forceps and then clip the little claws of the IOL onto the iris. So this is the inclination part. The forceps hold the lens, which is very slippery. These are actually MST forceps, but you can use a needle that comes with the set. You can see the fold of iris that just gets clipped in. You just repeat it on the other side, and that holds the lens in place. There's certain size criteria. You have to make sure the anterior chamber is deep enough, and we prospectively follow the endothelial cell counts in these children just to make sure that there's no chafing or causes of endothelial cell loss. And that's the end of the procedure there. Okay. All right. Last few things, just notes. Homocystinuria is associated with elevated levels of homocysteine. It has, the clue is the broken zonules. And the important point is that these children have an increased risk of thromboembolism with general anesthesia. And it can be tested for with just levels of homocysteine in the blood or in the urine. And these are the zonules you can see here. They're broken on the right. Microspherophakia can be autosomal dominant in Weil-Marchesani, associated with short stature and fingers. They get high lenticular myopia. This lens is prolapsed into the anterior chamber and causing antipupillar block and angle closure, which can lead to chronic angle closure. You can do the PI, you can do a lensectomy or vitrectomy, which is what was needed in this case. And finally, this is ectopia lentis of pupillae. We're seeing a lot more of this. If you see ectopia lentis with an abnormal looking iris, it's often associated with this mutation, ADAMTSL4, and the direction of the ectopia is opposite to the pupil movement. And be careful of iris support. These irises are very thin and hypoplastic. So in summary, congenital cataract outcomes depend on the timing of surgery, the surgical experience, and the compliance with follow-up and aftercare. IOLs after 6 months is reasonable, but not before, and I generally don't put them in before 6 months of age. The lifelong monitoring for glaucoma and retinal detachment is very important. And a final point is for ectopia lentis, it is important to try to establish a diagnosis, if only to monitor for systemic complications, especially those in the aorta and in the heart. So thank you very much. And I'll see if there's any questions.
We will allow Dr. Tavares to present the 2 clinical cases we have in there. And then we are going to discuss in a round table, and then we're going to make the questions and answers from the audience.
Okay, thanks.
Yeah. Let me put the presentation. Yeah. Hi, good night, everyone. My name is Dr. Mariana Tavares. I'm the fellow of Pediatric Ophthalmology and Strabismus in CODET Vision Institute, and I'm glad to present you the next clinical cases. The first case is the case of a 3-month-old girl who was accompanied by her grandmother, that is the legal custodian of the infant. She was worried about the size of the right eye, that is smaller than the left one. The patient had important history. Her mother lives with HIV and had drug consumption during all the pregnancy. She had poor previous checkup. The patient also is taking antiviral prophylaxis to HIV with Combivir and has a close surveillance by her pediatric infectologist. The physical examination of the patient, the visual acuity of the right eye was no fixation, and the left eye, she has a central steady and maintained fixation. A small angle exotropia, and also she had an absence of the red reflex and a total white cataract and posterior synechias. The diagnosis of microphthalmos with congenital cataract was made, and we performed we planned an exam under anesthesia. However, the patient didn't return to consultation due to the COVID confinement, and until vertical transmission of HIV was excluded. Now her viral load was undetectable. The patient underwent exam under anesthesia at 11 months of age with a corneal diameter of the right eye was 8 millimeters and 10 millimeters. The axial length was 70.5 millimeters, and the ocular ultrasound was without abnormalities. So we decided to perform a cataract aspiration, leaving the patient aphakic due to the small eye. I'm going to present you the video of the surgery. It was performed by the Doctora Castellanos. Previously, we made a 1 millimeter side port incision in clear cornea, and then with blue trypan stained the anterior capsule. Gently, we washed the anterior chamber with BSS. After that, we put some cohesive OVD, filling the anterior chamber. And with the second instrument, we left the iris making a 36-degree synechulisis in a pupil margin, avoiding to touch the anterior capsule. After, we decide to put iris hook and a square pattern to improve the visualization of the cataract. Surprisingly, we found that the patient have a microspherophakia. So we started considering different management of the situation, and we determined to keep a capsular bag with previous main corneal incision made. We introduced a cytostome to stretch this fibrotic anterior capsule. We took the edges of the capsular rhexis, trying to tear in by sheeting, but the anterior capsule was so elastic, and the traction of the zonal fibers make it the situation worse and difficult to continue tearing. So we decided to aspirate the cataract by the little rhexis, doing it by manual irrigation aspiration, starting on the underlying cataract prolapse and grabbing pieces and pull up and forward until all the capsular bag was clean. And then the posterior capsulotomy of the fibrotic plaque was performed with bimanual vitrectomy, looking for achieve a posterior capsulotomy of 4 millimeters approximately, and also an anterior vitrectomy was performed. Okay, so. And finally, we close the main incision, inside incisions with 10-0 nylon suture, as well bury all the sutures. And this is the final look of this surgery. Well, and 10 days after the surgery, the patient was admitted to remove the corneal sutures. A retinoscopy was performed with the following refraction. The fundoscopy was without abnormalities. Keratometries were taken 1 week later, the suture removal, for the contact lens fitting. Currently, she is on visual rehabilitation with contact lens and began with 5 hours at least of eye patching of the left eye. 3 months after the surgery, the patient maintained visual free access, normal intraocular pressure, although her grandmother and uncle have poor adherence to the treatment, they could notice better position of the eyes at front. In this case, the maternal germ consumption may affect the growth of the eye in response to prenatal insults. The cataract surgery and its outcome differ in infants with microphthalmos compared to children with normal eye development. The primary IOL implantation is controversial due to small diameter capsular bag and possible postoperative complications. And then I'm going to present you the next case. It is a case of a 4-year-old girl who came to the consultation because her mom said she gets too close to the objects and also take an anomalous head position since a year ago. No relevant history for the case. I'm gonna show you how the girl take the objects very near to her face. Her visual acuity of the patient was 20/160 for the right eye and 20/200 for the left eye. She had an exotropia of 20 prismatic diopters with complete ocular movements. Intraocular pressures were non-contact tonometry were 18 millimeters of mercury. At a sleep lab could observe clear corneas, iridodonesis in both eyes. Just in the right eye, could see the age of the displaced lens. After pharmacology mydriasis, we observed the inferior and temporal dislocated lenses with broken and curly zonal fibers in both eyes. A classic case of bilateral lens subluxation was made. Retinoscopy was difficult to perform, but refraction of the aphakic area was achieved. In the fundus photography, we see the vitreous clarity, normal posterior pole, oblique optic nerves with a small cupping and peripapillar scleral crescents. And here we have an image taken by the anterior, which is a sweep source anterior segment, OCT, and we can clearly observe the asymmetrical anterior chamber depth, the lens subluxation, and also some cellular fibers and detachment from the cellular process with vitreous prolapse. Other findings were joint stiffness and hand and fingers, an incomplete elbow apron extension, and her chest doesn't show abnormalities. Her height is taller for her age, and the genetic department evaluated her and didn't find in this moment suggestive clinic data to think about an Marfan syndrome, because at this age doesn't collect enough diagnostic criteria. We continue her follow-up requesting metabolic panel to rule out homocystinuria and send her to her cardiologist evaluation. The management plan with the girl was visual restoration correcting the affected zone. The last visit, she achieves a best correct visual acuity of 20/17 for the right eye and 20/60 for the left. Mother mentioned it, she likes her new glasses, which are with the next refraction, and also she had a better head position. In these cases, the early visual rehabilitation is essential. The follow-up of a systemic disorder as Marfan syndrome, Weilmar-Shahzani, and homocystinuria, which are associated with ectopic could determine the visual and life prognosis. Surgical approach may be attempt to avoid future sequela in these ectopic patients. And the optimal visual correction within the amblyogenic period is critical. Conservative management is preferred by many authors due to the lack of consensus about the age of the surgical approach. There are no randomized control studies in the literature specifically comparing the lumbar to pars plana approaches. Some believe that the surgical intervention must be performed until complications from the subluxation occur to justify it. And visual rehabilitation remains to be the state of the art of surgical techniques that requires expertise and advanced skills to be performed with the fewer possible complications. And that's all. Thank you.
Okay, thank you very much, Dr. Ali and Dr. Tavares. Dr. Ali, it was a very interesting presentation. It's a very specialized area, and I'm sure there are many questions from the audience. But I would like to ask you two questions. In the case of the microphthalmos, what would Dr. Ali have done in that case? With these measures, have you implanted an IOL, or what have you done in this case specifically?
I think that that was a very difficult case. The surgery was exemplary. With a small pupil and finding that the lens is very small. One question was, I didn't see it, but when you remove the plaque, did the lens actually expand out? Like, was it very phimotic, and did it sort of become larger, or that didn't really happen?
No, that didn't really happen.
So I mean, that bag was way too small for an IOL. So your corneal diameter, I think, was about 8 horizontally.
Yeah, 8 by 10.
Yeah, 8 by 10, and that was even small on that size. So you have a 5 millimeter bag. Your optic for most, for example, a foldable IOL is like 5.5 or 5. For a smaller IOL, it's way too large to fit in the bag. And if you are going to use a 3-piece lens to try to put in the sulcus, that again would be too large. And typically where people run into trouble is it vaults anteriorly, and it chafes the iris, and it can cause the angle to close. So I think I would not have implanted an IOL in that case. In cases like that, I've done the surgery as you had with the lensectomy and vitrectomy, and I've told the parents that if the eye does grow, then we could consider an IOL later. The other thing is, what power would you use? With the 17.5 millimeter eye, your lens power could be 45, something like that. There's really no IOLs that are available that could even get there. And that can sometimes be a problem in these children, even when they're older and their eyes are big enough to take an IOL. It's hard to actually find a good lens power that doesn't leave them, say, +10 with spectacles.
Okay, maybe combine them with a contact lens, maybe the IOL and then a contact lens would be an option. And speaking about the ectopia lentis case, I think the 2060 can improve maybe to 2050 or maybe a little bit better with treatment of the amblyopia she surely has. Would you still operate it? What would you do if it was your patient?
So that level of subluxation and distortion, I probably would have operated as well. In one of the pictures, at least on the picture on the left eye, I could see that the lens had dislocated into the middle of the visual axis. There was definitely some distortion. I didn't see a refraction, but I heard it mentioned that it was very hard to refract a child. So I probably, if seeing that, I would have gone ahead. And you can expect a better vision result in this child now than 2060. I mean, if you wait, I have seen children where people have waited until they're 11 or 12 and they've had permanent, their best vision is, say, 2100 or 2080. And the surgical risk is the same if you did it at 4 or 5 than if you do it at 10. So I don't think you would have gained anything by waiting. I think that was the right time to do it. And the child can now still regain, improve their amblyopia.
Okay, thank you very much. Any something you want to say?
Hi, I have a few questions. Hi, Dr. Ali. My name is Arturo Chayet. How are you? Thank you so much for being with us tonight. The presentation was really outstanding, and I wish you could stay 2 more hours because there's so many things that that you can share with us. And congratulations. We all know that your service and your center is second to none in terms of pediatric surgery, ophthalmopediatric surgery in the world. So we are very honored and pleased that you were able to be with us.
Thank you.
I have two main questions that I would like somebody to try to give me, a possible good answer. And they are both are on terms of the longevity. I'm very curious about the IOL longevity issue, the clarity of the lens, especially when you implanted in children. And I think that, intraocular lens implantation in children started maybe, on a large scale, maybe only 30 years ago. So probably it's about 30 years, the maximum somebody who had the surgery at age 2, who's now 32. I don't know how much you guys follow these patients since they are no longer children. Mm-hmm. And what is the current consensus about the longevity of intraocular lenses, the different type of materials? So that's one question. And the second question also is related to longevity, and it's about the Gore-Tex sutures. When you suture a bag, so anterior segment surgeons, they tend to believe that Gore-Tex sutures can last 40 years, but I don't know if you go and you're gonna suture a bag complex and the IOL, etc., in a 6-year-old, how long will that bag will last? I mean, I know that there hasn't been that long of a time, but I would like to see your thoughts about it.
Sure. So just onto the first question, the longevity, the lenses that were being put in 30 years ago, this was before I started ophthalmology, but they were mostly PMMA lenses. Yes. So PMMA lenses have a long track record, 70 years in ophthalmology. So there's no reason to suspect that they would break down. I think most of the trauma with the PMMA lenses occurred because of the surgery and the large, incisions and all of that. But generally, from what I've read, there's been no sort of epidemic of lens breakdown. I think the concern is mostly with the newer lens materials, where, for example, glistenings with certain hydrophobic acrylic lenses, some of the hydrophilic acrylics, things like this. There's other lens materials that have other problems like calcification. The most used newer material is hydrophobic acrylic, which are mostly actually the Acrosoft technology. And so those have been in most children's eyes, I would say more than 20 years now. It was done before I was a fellow for about 10 years. So it's been quite a while. Again, I actually looked because we had a concern about glistenings. And there's no reports of any congenital cataract or IOL that has been explanted because of glistenings. I've seen glistenings. We've shifted to a lens material which doesn't do glistenings, to a Bausch & Lomb lens, but it's still hydrophobic acrylic. So I stick to that type of lens material, but nobody has data on hydrophobic acrylics beyond 20, 25 years. I've just not seen anything, but I would have expected by now, if people are explanting them, we would have heard more about it. Most of the explants of those lens types I've seen are in adults, and obviously small numbers given the the millions of IOLs that are put in every year around the world. So I don't have a great answer for you, but that's all I have. Your second question is about sutured Gore-Tex suturing with segments and implants. I don't do that myself. I know that there's people who do it. There is a philosophical difference for those who like to do that. They like to do it to avoid opening up the posterior capsule and also to try to preserve the bag. In pediatric cataract surgery, those who are trained as pediatric ophthalmologists are actually quite comfortable opening the posterior capsule because you have to do it, else you have to go back in and redo those all the time. So a lot of the children who have the sutured lenses will have to go back to the OR and have a YAG capsulotomy or surgical membranectomy because they're going to get posterior capsular opacification. There's no evidence. I mean, Gore-Tex may live for forever. The problem is also on the scleral side. It can erode through the sclera, even if the suture itself doesn't break. And that's the problem that happened with Prolene, because people felt the Prolene doesn't break or snap, but it can erode through the sclera. So nobody knows the answer. The studies that I showed were for aphakia, which is what was done in the case that was presented. And for artisan lenses, the artisan lenses have been around for, again, about 30 years, and they've been put in children for 25, 30 years. And there's known issues with trauma, dislocation, and endothelial cell damage. With sutured lenses, the data is not as good. they're not followed for as long, and they're not followed in for things like vision in the same way. So I don't have a good answer for you. I think a lot of it depends on how you're trained. Most people who do cortex tend to be anterior segment surgeons who are comfortable with that technique. Most people who do lensectomy, vitrectomy tend to be pediatric ophthalmologists. And that's why you don't find good studies to compare them head to head.
So pediatric ophthalmologists, generally speaking, they basically don't do, or they don't like too much the suture of the complex, correct?
Yeah, by and large, I mean, some do. But yeah, by and large, if you relook at the papers, for example, that people publish, you can usually tell who the people are based on the technique. There are some who do it, and but by and large, that's what it is. And so it's not a question of what's right or wrong. It's a question of your perspective. And definitely removing the bag, doing a vitrectomy is something that pediatric ophthalmologists are quite comfortable with. So that's not really an issue. And then there's the technical side, obviously being comfortable doing that type of surgery. It's a complex procedure. It's obviously going to be much less common in children than it would be in adults. It's a long answer to your question. I'm sorry, I can't answer it definitively. I don't actually know the answer myself.
Let me ask you my final question. We do, for adults, we do the light adjustable lens. Mm-hmm. What would you like to have an adjustable, power adjustable lens, like you can put in children, and something that you can keep adjusting over time? Do you think it can be like a game changer for pediatric ophthalmology?
I think it would be very interesting, but it would have to be something that you could do repeatedly. And again, I defer to your knowledge. You have more knowledge about this technology than I do, but the refractions in these children can change every year, from until they're, 18, 19 years old. So I'm not sure how adjustable the lens will be, over that period of time. Yeah, so that would be the concern, not just like a target refraction, which is how it's used mostly, is just to sort of fine tune and remove small amounts. And the axial length growth in some of these children is significant.
Yes.
So you can have these children, change 5-10 diopters.
Yeah, no, so that won't be possible. Yeah.
Yeah, that's not, as far as I'm aware, the technology is not possible to do that.
Okay, very interesting. Thank you.
Thank you.
I think there's more questions, right, Adriana?
Yeah, there's another question from Dr. Avila, but would you want to do it yourself, Dr. Avila?
Yes, hi to all. I'm Dr. Avila, and I'm a specialist in cataract surgery in pediatric population here in CODET Vision Institute. And I have two questions for you, Dr. Ali. The first one is the same adjust correction during surgery when you decide the sulcus IOL placement that in adults, it's the change of a half diopter power? What do you recommend in pediatric surgeries?
So the 0.5 is sort of a rule of thumb in adults. The actual amount of correction depends on the IOL power. So the higher the lens power, the greater the adjustment. So it can be 0.5, it can be 0.75 and 1. In children, often you're using higher powered IOLs. So it's actually important to know the different numbers. What I recommend is Warren Hill. He's a cataract surgeon. He does a lot of stuff on IOLs and formulae. He and his website, drhill.com, I think it is. You can actually see a table on IOL powers and adjustments for sulcus power. So if you know your IOL power, you can adjust it for the sulcus there, and it can be more than 0.5. It can go up to 1. So 0.75 and 1. And because in children, you can have an IOL power which is 30, for example, and which is much higher than what you would use in an adult.
Okay, thank you. And do you consider outdate the AAO recommendation to adjust the IOL residual refraction to accord to age of surgery? We have we used to calculate around a special table that recommends the American Academy of Ophthalmology.
I don't remember that one because I'm sorry, I don't know exactly which one it is. There are so many different papers on this. So some of my fellows, they like to use sort of age. There's different things. Some people use a formula age plus residual power equals 6. So they'll give up to like a +1 until about 6 years of age. There are papers on percentage decreases in power, for example. So that's why I don't know one off the top of my head. I'll usually just use the one up to about 4 years of age. But my point is that there are a lot of other factors that are there. If you walk in and both parents are myopes, you're going to be pushing the child to hyperopia. And I have seen children, it's a very inexact science, honestly. So you're fine to use any published table you like. I would just look, if you follow the children yourself, you'll have a sense of which way they're going to go. If you look at enough of these papers, you'll find that most of these recommendations, there's a lot of variability in how the children will turn out. And you can get very large refractive shifts or none at all. And it's very hard to tell just by looking. Sometimes the family history is helpful, sometimes it's not. And so I don't think it's outdated. I don't think that I've given more evidence. I don't think it's out of date. I think you just need to know that evidence and that evidence base is generally quite variable, and you'll expect variability, and the parents should be told that.
Okay, thank you so much.
Yeah, I think it's not outdated, just you have to consider all the factors around the patient, and it's very specific to every patient, the thing that you calculate the IOL. Okay, any other questions from the audience? I see 41 participants. Thank you.
I have another question now, if I have a chance. Dr. Ali, for microspherophakia, if the patient has, let's say, normal intraocular pressure, will you say that that means that the zonules are not as bad, and then you will go ahead and maybe just put the lens in the sulcus? Or how do you decide your approach? Let's say, depending, how can you tell how badly are the zonules in microspherophakia?
So you tell by how shallow the anterior chamber is. So what you find in these children is that they progressively shallow over time. I actually did a case 10 days ago, and this child who came in, and his baseline anterior chamber depth was 1.5 millimeters, and he came in for a regular visit. He was blurrier because his lens had moved anteriorly symmetrically in both eyes. He had an AC depth of 0.75 because of microspherophakia, and it was all because his zonules became loose. So the way you can measure it with refraction, but also with axial AC depth. And then of course you look at the angle. So his angle was nearly just a slit. So if you can do gonioscopy or you can do anterior segment, you have a good anterior segment OCT image you showed. That's also a good way of monitoring them as well. Before they get into angle closure, before they get into elevated IOP. Because once they get into that, they can go into acute angle closure, and then they can develop chronic angle closure. So if you at that point you're obliged. There's a bit of controversy in terms of when do you do surgery before that. There's some people who will do it right away. I like to see some kind of progression, or at least an occludable angle, before I convince it, because the children see normally. They have clear lenses. You give them glasses, they can see absolutely fine. And you're talking about a prophylactic surgery. And then IOLs, I don't recommend. The bags are usually very, very small. They're too small even for capsular tension rings. Maybe segments. There's a case report of people suturing segments, but these bags are often really, really tiny. And you better off just leaving them aphakic. And then if you want to do something else later on, you can, various different ways of secondary IOL placement later. And that's what I did at this patient. Bilateral lensectomy, vitrectomy, remove the risk of glaucoma, open up the angle, and then he has the option for whatever technique he wants down the road.
How old was that patient?
He was 10.
10
He was 10.
We have a 17-year-old
Mhm.
that she's developing increased myopia, and I can see that there's a starting of a nuclear sclerosis in that patient. So I told her, I think this is a good time to do your surgery because we don't want you to go into, angle closure glaucoma. And also I think that that the zonules probably are not as bad. So we can probably place the intraocular lens, a 3-piece intraocular lens in the sulcus and just maybe capture the optic in the bag. So that was kind of, but she hasn't decided that she wants to do it.
So just be prepared and prepare the patient that the rest of the zonules may come apart. So when I see these cases, the IOL will actually just bounce around. It's almost completely loose. And I went early in my career, I had left some of the bag actually for that reason, and it would actually progressively sublux over time.
Oh, wow.
So it's a progressive zonulopathy. So, I mean, people have done it, and every case is different, and there's obviously degrees of disease, but to just be prepared when you go in, you may find that the zonules may be compromised, and you may have to do another, however you choose to handle it. You may not be able to use the bag for the IOL support.
Wow, that's very interesting. Thank you.
And how much time does the IOL takes to the subluxation?
In what situation? In this?
In this situation that you place the IOL sutured and then all the fibers.
Oh, I had left the bag in that case, and I had left it to put the IOL in later, and the lens sort of capsule complex came into visual access within about a year, and so I realized that I sort of learned a little bit. I had to go back in and actually remove whatever was left over. And I had also tried, or again, early in my career, I tried to put a capsular tension ring. It actually overlapped for about 3 millimeters. I got it in the bag, and then I touched it, and it ripped the bag in half. So these are not easy cases. There's, I think, 2 case reports of people. There was 1 case report of a CTR, and 1 more of it being sutured in with segments. So I think it's possible, but I think you have to have some experience and be careful of what you find when you go in.
Dr. Ali, what do you think about multifocal intraocular lenses in children?
I think that people have done them. I think in general they have to be much older, so you have to be an age where there's not much risk of refractive progression. So there's a paper by Ed Wilson that looks at this at axial length elongation in sort of later childhood, later teenage years, so the second decade of life. And he found that in a lot of children, there is a change in their axial length later on. It's one of the reasons why, for example, refractive surgery, most people won't do it until you're around 18, because you can have that little bit of residual axial length elongation.
Right.
And so that you generally want to do your multifocals with someone who's not changing their prescription very much. You could do it with glasses, for example, but it's not as effective in terms of refractive outcome. One of the things is for people, some people have done them in late teenage years without any trouble, and they get good results. One of the things in younger kids is that you want your maximum contrast for treatment of amblyopia. So that's a reason not to do it in very young children. But people have done them. I don't do them, but people have done them. I usually just put them in progressives.
We can say that they're not that popular in the ophthalmopediatric community.
I don't think so. I think if they're late teenagers, then I think they're treated like everybody else, and I don't think there's any problem with that. I think in younger children, I wouldn't do them, and I haven't done them.
Excellent.
Okay, if there is no other question, I want to thank you very much, Dr. Ali. It's a little late in Toronto, so we are going to allow you to get to sleep. And we are very thankful to take this session with us, and very nice to meet you.
Thank you very much. Thank you so much for inviting me, and good night.
Good night. Thank you.
Good night.